Mainstream Mental Health Radio with Dr. John Huber.
What do you think you are, crazy or something? Well, you're not.
We're on a mission from God.
News, issues, revolving around mental health. Dr. John Huber, a mental health professional for over 20 years, the chairman for Mainstream Mental Health, a clinical forensic psychologist, and a psychology professor at Texas State University. Breaking the silence of mental health, one day at a time, discussing the human condition, providing a sounding board for mental health issues, and making mental health mainstream.
You got a gift, my friend.
Now it's time for Mainstream Mental Health Radio.
Let the healing begin.
With Dr. John Huber. Listen to Mainstream Mental Health Radio with your host, Dr. John Huber. Check us out on social media, Google+, Mainstream Mental Health, Instagram at Mainstream Mental Health, Twitter at Mainstream MENTL, and search for Mainstream Mental Health on Facebook. Please tune in every week to Mainstream Mental Health Radio with your host, Dr. John Huber.
Good afternoon. You're listening to Mainstream Mental Health Radio Show. I'm your host, Dr. John Huber. Please follow us on Mainstream Mental Health Radio and share our website with your friends and family at mainstreammentalhealth.org. Also, you can find us on the Mental Health News Radio Network, and welcome to our show. Today we have a special guest, and it's kind of unique, something we haven't done before. We always talk about mental health disorders, whether it's depression or schizophrenia and those types of things. But today we're talking about a treatment modality that is considered by many on the fringe. I know a lot of the physicians I work with cringe at the thought of some of these alternative treatments. A lot of the doctors, though, are very excited about them, and they have a lot of positive experience working with them. So today we're going to talk about using ketamine in order to treat disorders like post-traumatic stress disorder, depression, even some addictions like alcoholism and other types of chemical dependency. So what we've done is we've been in contact with an amazing physician who's been very open and honest and allowed me to tour one of his facilities and even experience some of the treatments themselves. So his facility is called Klarisana, and you can find that at klarisana.com. There will be an attachment with the exact website and everything else to follow. But today I'd like to recommend and introduce Dr. Carl Bonnett. Dr. Bonnett, how are you?
I'm doing well. John. Thanks for having me on your show.
Well, Dr. Bonnett, now, if I remember correctly, you are trained as an emergency room physician, and you are a veteran as well. Is that correct?
Yes. Yeah, I did 20 years in the Army National Guard and trained as an ER doc. This is my background.
Well, what got you into looking at ketamine as a treatment for some of your patients?
Well, ketamine is an interesting medication. It's kind of interesting, the different specialties who are now looking at using ketamine for mental health because, traditionally it's a medication we've used for a long, long time in the emergency room. I mean, anesthesiologists and emergency room physicians have used ketamine as a sedative for quite a while. It was invented in the late 60s. It's been in use since the 70s. In the military, we use quite a bit of it. So we've had a lot of experience using it in its traditional form for, as a sedative agent. But then when some of the studies started coming out showing that it could be effective for treatment-resistant depression, PTSD, and whatnot, it kind of caught the attention of a lot of us in emergency medicine and anesthesia, because this is, of course, a drug that we're very familiar with. And then for me personally, with the military background, I've had a couple of folks I've known, unfortunately, ended up taking their lives after military deployments, and just indirectly work with a lot of veterans who are, at high risk for that kind of a thing. So when I saw this as a possibility as a PTSD treatment, that certainly caught my attention.
Now, when you're using it for these alternatives, you're not actually sedating and making a person go unconscious. Is that correct?
Yeah, that's correct. I mean, and that's where it gets a little tricky for people to wrap their arms around this, because a lot of folks are used to the idea that ketamine is a sedative agent, and in that regard, it's part of the anesthesia realm. But it's using the same medication, but in a fundamentally different way, and in what we call ketamine for non-anesthetic indications, KNAI. And that means that unlike in a sedative situation, we're not giving a bolus of the medication. So, if I see you in the ER and you're using it for sedative, I'll give you a rapid push of ketamine all at once to make it, basically disconnect you to allow a painful procedure to happen. Here, there's no bolus, and we're basically running it as a drip over an hour. So that's one of the key differences is that the patients are awake and responsive, and in fact, when we combine like ketamine-assisted psychotherapy, they're able to actually have a therapist work with them while they're getting ketamine. So that is a bit of a paradigm change for a lot of clinicians to think about ketamine being used in just a very radically different way.
Exactly. Now, ketamine has some special qualities and properties, and one of them is, my understanding, the amnesic properties of it, its ability to basically make you forget certain things and certain processes. Now, is that something you use as an advantage for you using this therapeutically like this?
We do. I guess I'm not sure I would use the word amnestic per se. Like, for instance, the benzodiazepines like Valium, Xanax,
right,
and whatnot, they have a tremendous amnestic quality to it. Ketamine has it radically changes your thought paradigm. I mean, if you want to use the common parlance, it's the psychedelic effect. But people are quick to dismiss something if we use the psychedelic, that word, just because there's a lot of preconceived notions and whatnot. But what it's really doing is, it disconnects you a little bit from the world, right? So the visual stimuli look different, things sound different, but more importantly for what we're doing, it really does, I think, allow you mentally to kind of step outside yourself a little bit. So a lot of times folks are sort of locked in a certain thought pattern, and the ketamine allows you to kind of step outside of that pattern a little bit and kind of analyze yourself from a more objective position.
Now, my understanding and the reading I've done, and maybe for some of our clinician types that listen to our podcast, it basically disrupts some of the communication between the medial prefrontal cortex and the amygdala. Is that your understanding, or am I not getting that right?
Yeah, it's a complex medication, so there's a component of doing that as well. It definitely has a powerful effect on the limbic system as well. Exactly. That's the kind of the thing that we don't know exactly how it's working in this regard, because and that's maybe what you're gonna ask next. But there's kind of two schools of thought as to how ketamine works. Because the traditional paradigm in American medicine especially is that, we create a medication, it hits certain receptors that either blocks or stimulates those receptors, causes some chemical change, and then that causes your mood to improve, or your, whatever the case may be, some effect is desirable. And then we can go and market that medication and make it commercially successful. Now, ketamine is kind of an interesting animal, because a lot of people are locked in that thought process that, well, it must just hit receptors. I mean, it blocks the NMDA receptor,
right,
maybe it increases brain-derived neurotrophic factor, blah, 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 all this kind of stuff. And they think that that's all there is. It must be just receptors. So this concept, and we believe that too, that the receptors are a part of it. But the idea that the, quote-unquote psychedelic aspect of it can be therapeutic, that is a very radical and fairly disruptive idea, and one that honestly I thought was kind of nuts. I mean, back in 2015, I got to meet a couple of psychiatrists out in California, Dr. Terry Early and Dr. Phil Wolfson, who really turned me on to this idea of, that the psychedelic experience can be therapeutic. And honestly, at the time, I mean, I was, I'd done 20 years in the military, and I'm anything but a hippie, right? So like this idea was pretty radical to me. But as
right,
taken this back and implemented it clinically, I'm a firm believer that that's a big part of what's actually going on here.
Well, and that sounds like a lot of the research and stuff that the LSD researcher Timothy Leary talked about, and how that may be able to do it. Only I think Timothy Leary kind of took things to an extreme, and it wasn't really as controlled as your process is. And I say that because you were kind enough to actually allow me to experience a treatment cycle, and that was something I felt like the whole time, that it was never out of control. There was always people in the room with me, and I always felt very secure that if something went crazy, that there would be no bad effects or anything else, because people were there monitoring the whole time. And that's not what I remember reading from Timothy Leary back when I was an undergraduate.
Yeah, I think part of what when we claim that the experiential part of it's important, that's predicated upon the patient being able to feel that their body is secure, right? I mean, for you to be able to let go and just kind of experience that headspace that we create and whatnot, you got to know that you're safe, right? So I mean, that's why.
Right.
We try to do it where you have one of our staff members monitoring you the whole time, and you're in a private room and all this kind of stuff. And it's somewhat humorous. Like occasionally we'll have someone make a comment on social media, making fun of one of our posts and say, "Oh, I snorted some ketamine at a party one time, and it was, I felt like I was a frog and whatever." I'm like, well, when you're at a party and you're mixing it with alcohol and who knows what else, it arguably is a very different clinical context than what we're trying to create in our centers.
Exactly. And it's interesting because as I've talked with different people, I mean, I was on a radio show and I mentioned Klarisana and you on a radio show earlier this week, and off the air it was like, one of the producers like, "Oh man, I remember, doing that when I was in college," and yada yada. And I was like, wait, it's a totally different situation, that's totally uncontrolled, and you don't know what you're getting mixed with your medication and all that kind of stuff. This is very clinical, and you said it makes you feel, everything makes you feel very safe and secure in the whole process.
Yeah, the context is everything, right? I mean, the context is huge. I mean, think about, when you go to a 5-star restaurant, they serve you some really nice food and all this kind of stuff. Well, hypothetically, if we took the exact same food and put you in, a gas station on the side of some highway and, sit you down on the floor and serve that food to you, I mean, would it be that same experience? No. I mean, the ambiance and everything is a part of it, the way you create it. That's why, you can't put several patients together. The traditional idea of an infusion center where everyone sits around in a lounge chair next to each other, getting infused and talking about sports or whatever, that doesn't work, man. The context of how it's done is huge. And certainly if you start mixing it with, other stuff, like alcohol and whatnot, man, it would become a completely unpredictable scenario.
Exactly. Now, let's talk a minute about what you think is going on when we're specifically using it for post-traumatic stress disorder. I want to talk to you about that and then maybe contrast that with what you think is going on with, for example, chronic pain management. So let's start with the PTSD, post-traumatic stress.
Right. Well, for post-traumatic stress, observationally, when we talk to our patients, they've given us some really interesting insight. And that really supports, in my mind, the idea that the experiential / psychedelic aspect of it is huge because, it seems like there's kind of like a psychological or a psychic paradigm that you get locked into after something very, very horrible happens. And, you just keep seeing that over and over. I mean, obviously re-experiencing and whatnot. So, we had one veteran who really put it in a cool way for me. He was a gentleman who was in the 82nd Airborne. He'd seen a lot of action in Iraq and seen some really horrible things. And when he his family brought him to us, and he had tremendous anger, and he was just really, really high-strung, and the family was really concerned, somewhat about their own personal safety with this guy. So when we started doing the infusions, after about the third, I think it was the third or fourth infusion, he told me afterwards that he had kind of this vision, and this is where it gets a little bit interesting, because sometimes people say that ketamine is a hallucinogenic. Well, it's not exactly. You're not going to see a penguin walk across the room or something like that, but people do describe kind of these insights and these visions, and then like kind of an understanding of the universe that, I don't think they're necessarily saying that they saw it in the physical being, but anyway, so he had this sort of vision where he was thinking, he thought of Iraq as a Western movie. Like when you go to a Clint Eastwood movie in the theater and you're watching it, and you see the horses and you see the saloon and the gunslingers and all this kind of stuff. You think you're back in the 1800s. You're just kind of locked in this idea that I'm in that zone. But the thing is, he had this vision where like the camera backed up a little bit, and he was able to see a food truck and computers and hairstylists and all this kind of stuff. And he realized, oh my gosh, it's not 1835. This is a Hollywood set. And afterwards, he was just like, dude, I don't know how to like explain how that applies to Iraq. But he said that for him, he sort of things pushed back, and he just sort of saw that everything he was thinking of is not what it really is. And he now had this new like image of it, which again, it's very hard to explain. And if you could explain it in words, then you wouldn't need ketamine. I think by definition, we're dealing with this realm that's beyond verbal description. But he's just like, now I can see Iraq as this different entity. I can put it on the table. It's still there. He still remembers it. He still, remembers the people he lost, et cetera. But he's able to now compartmentalize it and get out of it. And that's what is really, really cool when we see that happen with the ketamine patient. And of course, those doses tend to be a little bit higher to maximize that psychedelic aspect rather than what would historically be used in what they call the NIH protocol.
Okay. Well, and it's funny you mentioned that, because I brought in a video. A friend of mine had given me a brand new DVD that had come out with videotape from blues guitarists like Lightning Hopkins and John Lee Hooker, and all these people from 20s, 30s, and I started having that kind of experience too. I mean, the sound quality was already amazing. That was verified by the staff that was there with me watching it, and the video call, they fixed all the scratches and stuff on the video, and it was very clear, sharp images. But in my mind, I saw them just coming off working out in the field and all this kind of stuff. Because, I mean, you see these guys, and, they were dressed as well as they could be, but you could see that, there wasn't a lot of air conditioning, and they were sweating, but you could also, I could feel all that emotion that they were transmitting in their stories that they were singing about, and much more than I had ever gotten before by listening and watching those individuals. So it was very difficult, and it still is difficult to quantify and tell you the extra perception that I got by watching that with the ketamine. So.
Right. And the thing, too, that you got to keep in mind is, we did a little, trial for you of a single infusion, but all that really tells you is, like, oh, interesting, this is kind of interesting stuff. Where you really get something out of it is on the subsequent ones. So we have a little bit of an inside joke that, on the first infusion, the ketamine owns you, and after that, you own the ketamine, meaning, like, how to operate in that space. You know what to expect. You know what to do. That. Whereas the first one, you're just like, whoa, that was kind of weird.
Right. It was totally foreign to me. I mean, I'd never experienced anything like that before. And it was, somebody's like, oh, was it like drinking too much? I go, no. What I remember is from about the collar of my shirt up, my throat just went numb, and it felt like my teeth were floating in my mouth. Like I'd been given a whole bunch of Novocaine shots in my mouth. And that was the first thing I noticed. And then I was just kind of there. There really wasn't much after that as far as feelings in my body and stuff like that.
Right. Yeah, and potentially on subsequent doses, we always start relatively low so as to not scare a patient. But the goal is
right.
to increase the dose to get to the point of what we call the psychotropic therapeutic response, which is kind of a term we made up that just sort of describes this optimum space where the dose is high enough where you have a really intense kind of transpersonal experience.
Okay.
But at the same time, you're still with it, right? You're at all times you're responsive to verbal stimuli and whatnot. But the analogy we give is it's kind of like riding a motorcycle on the Pacific Coast Highway. If you're going too fast, if your dose is too high, your speed's too fast, you're gonna be scared. You'll be white knuckling it through traffic and whatnot. If you're going too
right.
slow, you'll be like, a motorcycle can't go too slow, and people are gonna be fall over. People will be honking at you. So there's this optimum dose, or like in the motorcycle analogy, the optimum speed where you're like, wow, here's the water, here's the beautiful houses in Malibu, and I'm just cruising. So that's the dose. We didn't get that dose for you because obviously we just did a single one.
No.
So we've learned we don't want to overdo it on the first infusion. We think that PTR, that point, is where people really get something out of the experience.
Wow. Well, and it felt pretty powerful to me. I mean, of course, again, I had never experienced anything like that. So, and it was pretty amazing. Now, talk a little bit about the chronic pain management, because as we were doing it, I'm thinking, okay, I've got a bad shoulder, I've got steel pins in my shoulder, and I deal with chronic pain, and I've learned to manage it. And I thought, that would be something I would go back for if I was going to use it for a treatment. How does that work? And I know we talked about this in your office, so I'm going to try not to give any away, so I'll let you go.
Yeah, chronic pain is interesting. It makes ketamine a little bit of a challenge to market because it sort of does these two somewhat distinctly different things through different mechanisms. But, of course, there is a tremendous amount of overlap between those cohorts of patients, the chronic pain and the folks with depression and whatnot. But if you're looking purely at chronic pain, let's say we look at like neuropathy, for instance. So what you've got is usually a condition called central sensitization, which is kind of a $5 word that means that, when you get all these impulses, these pain impulses hit the back part of the spinal cord, the dorsal horn, it sensitizes it. It causes this thing called wind-up, which then creates this chemical called substance P that goes back out to the periphery and causes more inflammation. Then that goes back and hits the spinal cord again and goes back. So it becomes this feedback loop. Right, so it's kind of like putting a microphone in front of a speaker at a wedding or something. Right. You get that squealing sound, and that's what people are feeling. And then the problem is a lot of people then end up resorting to opiates to try to get that under control. And then you get, of course, we know you get tolerant to opiates, requiring escalating doses to get the same effect. But then there's also a really dark side of opiate medications that a lot of people aren't necessarily aware of, called opiate-induced hyperalgesia, which again is one of those big $5 words that means that over time the opiates start to sensitize the pain receptors and they cause their own pain. And at that point is when you really get into a kind of a non-recoverable spin, which is, that's a real dark area as far as leading people towards the overdose, which, we know there's, 40 people a day overdose and die on prescription narcotics. So the thing with that cycle, that central sensitization, is that it's mediated largely by the NMDA receptor, which is the receptor that ketamine blocks. So it's fascinating. So it's with these people with neuropathy and this chronic pain, when you're hitting them with narcotics and you're doing all this kind of stuff, that is kind of just like, going to a locked door at the front of your house and you're trying to open it with every key you got and it's not working. And then ketamine is getting the bright idea to go around at the back and just find that the back door is unlocked and go in. It totally subverts the whole process because it goes right to the receptor, the NMDA receptor, and can derail that. So it's not a cure, right? I mean, it's not. It'll still come back. So people do need booster infusions and whatnot. But the point is, especially those folks who have gotten not only tolerant to opiates, but who've got into that opiate-induced hyperalgesia, it could be a valuable resource to give them a very alternative mechanism to try to break that pain cycle.
Huh. Now, one area which I'm very interested in, because I have a couple of patients we've been talking about and about dealing with their alcoholism. What do you think the mechanism is that allows alcoholics to finally be able to refrain from or not be interested in their drug of addiction or drug of choice anymore.
Yeah, that's interesting. And again, this is purely conjecture. So, like, if
right,
I don't have any solid evidence to point to, but anecdotally, we've had a lot of patients, who have really have a tremendous dependence on alcohol, and it's also actually for benzodiazepines too. So they're somewhat equivalent. People who are on Xanax and whatnot. But in either case,
right,
they're taking these medications, and we've had a number of them really be able to decrease their usage dramatically. And that is a good question. Again, a lot of people will start pointing to, like, well, what's the receptor? It must be some receptor. You must have modulated
right,
some subtype of the serotonin receptor, and they don't want to drink Jim Beam anymore. Well, I don't know, man. That's a part of it. But I think a big part of it, too, is, people are locked in a certain thought pattern. For instance, there's a gentleman who actually, he did a documentary video for us. You can go to our website, our YouTube channel, and watch his story. He was a guy who got drafted during the Vietnam War and spent 18 months working in the burn center at BAMC. So he did death determinations for burned veterans coming back from Vietnam War. So he did the EEG monitor to determine brain death. So he was saying, dude, for 18 months, these horribly burned, charred, bodies. It was his job to, make death determinations, and it really, really messed him up. And he got to the point where he was drinking just a tremendous amount of vodka every night for like 40 years. And then we infused the guy, and it was kind of a side. I mean, afterwards, when we were kind of done, he was just like, what's interesting, Carl? I actually haven't had anything to drink in the last 3 weeks that we've been doing these infusions. And then later, when he came back and did the video for us, he's like, dude, I stopped drinking. I mean, after 40 years, I stopped drinking. I don't drink alcohol anymore. And we've seen that play out with other people. I think what happened is he was locked in this feedback loop, this mental feedback loop of, seeing the bodies, doing this, his experience from that time period. And the ketamine kind of broke him out of that and allowed him to almost be a new person or something. So again, this is conjecture. I can't prove that, but anecdotally speaking to patients, they just say there's a different understanding that they get. One guy actually put it real nicely. We talked about the idea from Zen Buddhism, where if somebody asks you, what's the sound of one hand clapping? A lot of your listeners have probably heard that concept, and the answer is that the Zen master comes up and just slaps you in the face. Meaning you can't articulate an answer. You're right. The answer is experiential, right? So that's a great example this guy came up with, where what's the sound of one hand clapping? Well, the answer is experiential. You cannot articulate that in the English language. In the same way that what's the answer? What is the reason your 3 buddies died in that ambush in Afghanistan? Well, if you could articulate that in English, then simple talk therapy or CBT or something like that would work very effectively. They need something that's the equivalent of the Zen master slapping them in the face. And ketamine has a way of doing that. So I think that's what's happening with the alcohol too. Is that because let's say I'm not saying about you, but let's say you were drinking a lot of alcohol because you were bummed out about some event that happened in your life. If I could plug into you and become you for a little while, I wouldn't be bothered by that event. I mean, I'd be like, hey, that sucks. I'm sorry that happened to you, but I'm not going to go drink because of that event. So I think what ketamine kind of allows is the person to have a little bit of a reset where they could be someone new and then go back into that and be like, well, you know what? I'm not going to use alcohol as my mechanism, my defense mechanism for that anymore. So that's my theory anyway. It'd be interesting to try to figure out how to prove that, I guess.
Right, and and it sounds like also, I mean, because a lot of the people I work with drug and alcohol addiction, they have underlying depression and things like that they've used the alcohol as some way to mediate that, and I think that makes a lot of sense to me as a therapist, because all of a sudden, they're looking at their depression totally different, and they may not be getting depressed over whatever caused it in the first place, because they have that different perspective, that slap in the face, so to speak.
Yeah. And anecdotally, we've noticed that it's much more likely to succeed in somebody who is kind of either an isolated alcoholic or using kind of one substance for their as their treatment. We've had a few people come to us who are just like, yeah, dude, I love to use LSD, I love to use cocaine, I love to use this. I mean, it's just like, whoa. I mean, some of these like, this subtype of folks who are just these poly substance abusers. I think they just enjoy doing substances, and for them, ketamine is actually probably going to be counterproductive because we don't want to add one more.
So monosubstance addiction as opposed to polysubstance, because I think polysubstance users that there's something else going on there, and I think it has to do more with the pleasure centers and that reinforcement right there.
Right.
Versus some of these underlying psychodynamic or psychologically induced addictions and things like that are going on. So
so we'll hopefully put together a research project to look specifically at that. We have noticed we're just finishing up a research project. We have an IRB approved project looking at 30 veterans that we do infusion. We did the PCL5, which is a PTSD checklist, the PHQ-9, the DAS-10, and the audit, which is an alcohol screening. And we have noticed, in general, a decrease in their alcohol use before and after. So, unfortunately, that study only has 30 veterans, so it's not really powered to show a great change. But there's some suggestion that there's a decrease in alcohol. So it'd be great to do this with a much larger cohort of patients.
Definitely.
Definitely. Yeah.
Well, so, I know you and I talked in your office, and we talked about, what your basic setup is and what your expectations are for the patient. We talked about 5 to 6 treatments over roughly a 3-week period of time, and you can modulate that plus or minus depending upon the patient's needs and things like that. And, this sounds like, on the surface to somebody who's never heard it, this is some kind of magic pill. You go in there and you get that done. But there's actually a lot of psychological work that's going on in that process. It's not just going in there and taking the medication and, you wave goodbye to them at the end of the treatment and it's over. So maybe you want to talk a little bit about that and follow-ups and that type of thing.
Yeah, there's a couple. The original study that came out of Yale is the one that sort of, I guess, codified the idea of doing 6 infusions. And honestly, that number is somewhat arbitrary. Could have been 7, could have been 5. But most clinics around the country do 6 infusions. And I think that there is some truth to that, right? There are a few people out there who are making advertisements saying, we'll give you ketamine and you're going to notice within hours that, you're better and all that sort of thing. I think that is very, very disingenuous. And, I think where it really comes from, there's one study where there's a slight improvement in, a few-point improvement in the Hamilton Depression scale after 1 dose of ketamine. And that may be true, but I'm not sure that's necessarily clinically relevant. But the point is that when you say something like, I'm just going to give you some ketamine and it'll make you feel better after 1 infusion, you're treating it, again, as a purely biochemical reaction. You're thinking of it as Drano. We have a clogged drain, and we need to clean the drain. When you get several infusions over the course of 3 weeks, and especially if you combine that with a couple sessions of ketamine-assisted psychotherapy, where you have an LPC or LCSW or someone doing therapy with you during or immediately after the ketamine, that is the process is what's really, I think, getting you there. Because again, you only get to experience 1 infusion, but when you do 6, the interesting thing is that we tell patients is that who you are as a person is changing between every infusion. So again, that's where this is very, very different than like an infusion of Remicade, for instance, for rheumatoid arthritis. In that situation, the goal is simply to get Remicade out of the body, put it in the body, it hits its receptors, does its thing, makes you feel a little bit better. It is a development, so, we'll see this a lot where, like, especially sometimes a lady will come in, like, at the beginning of the infusion, hair's a mess, they're just kind of all disheveled, and then, like, by the 3rd infusion, we notice, like, you did your hair today, you put on makeup and whatever. And it's funny because you will ask the patient, like, well, how you doing? Are you feeling amazing? And they might be like, well, I don't know. I don't know. And then you'll say, you know what? You're doing your hair. Or the family member will say, hey, they did their hair, or they went for a walk last night for the first time in 10 years. So the number of infusions is not at all like, oh, you need 5 laser treatments to make your teeth white, right? That's purely you just keep hitting it again and again to knock down that discoloration. This is an active process where the patient is psychologically maturing and going through this process. And, because we'll see patients do that where they, like, on subsequent infusions, they'll say, hey, I just made a special playlist for this infusion that I want to listen to this time, or they're going to bring in some art that they want to work on. Like, I brought in these colors that I want to work with, and I want to, like, do a watercolor while I'm doing this. I'm like, okay, cool. Whatever you want to do. Or, so you see people work through things. And then, which is kind of fun. It makes it a little more challenging for us, but that's also makes it a little bit more fun in the sense that, like, when someone comes in for their second infusion, their third infusion, whatever, you sit and talk to them. You're like, hey, what's going on? What's going on over the last 24, 48 hours? And they'll talk about what they're thinking, and then you decide, well, should we increase the dose? Okay, cool, let's go up a little bit or whatnot. And it's an active deal, so it's kind of like, there's multiple variables, X plus Y plus Z equals 10, and it's always changing in between every infusion and trying to get that maximized. So that's kind of what we do over the course of the 6 infusions, and then the thing is, after that, people, sometimes people will be critical and then say, oh, you need a booster in 2 months, the effects aren't permanent. Well, that logic does not make sense, because to take a medicine like insulin, for instance, it's an incredible drug that saves millions of lives. If a diabetic does not take their insulin, well, guess what? Their sugar's going to go back up, right? But no one's harshing on insulin, saying, well, it's not a cure for diabetes. Well, okay, I'm sorry. I wish I could wave a magic wand and cure your situation.
Right.
But the thing is, they're also missing the point, because if you talk to our patients, most of them really, really want to come back in 2 months. Because I think that there's a certain amount of kind of like, mental anguish or whatever, and they really look forward to the idea of getting back in that chair, back in the clinic, refocused, have that experience, and it's therapeutic. It's not just like refilling the gas tank. It's not simply, we need to give you more medication or whatnot. It really does give them a chance. A lot of them want to come back, and they want to do certain meditation or listen to certain music or whatever and whatnot. So that's kind of the process of how it goes. And a lot of our patients are treatment resistant, right? So they've failed every medication. So
right.
Arguably, if you could be in a situation where, like, okay, great, you get 1 infusion a month, let's say, and in the meantime, you're not taking any other medications, not having these side effects of, as you know better than I, some of the side effects of some of the psychotropic medications,
right.
can be pretty significant. Right, so I've got a number of patients who are like, I come back every 2 months and I don't take any other meds. Some people do need to continue taking other medicines, and we work closely with their psychiatrists and psychologists and whatnot to try to, optimize that for them. But but the fact that you have to come back for a booster is not, I do not think is a shortcoming of ketamine or in any way a failure of it. It's just kind of, that's how the process works.
Exactly. Well, okay, Dr. Bonnett, we have a little bit of time left. What I'd like to do is, why don't you tell everybody where you're available, Klarisana is, and again where they can find you, and do you have any expectations that your research is going to get published, and if so, where?
We do, yeah. I mean, to start with, currently we have centers in San Antonio and Austin, Texas. Like I said, I can still have a link to our website, Klarisana.com. Feel free to get on there and check it out. We'd be happy to talk to you about, what we do. We're hoping to open another center at some point in Colorado, so we're working on that right now. And hopefully by the end of the year we'll have that up and running. As far as research, research is a big part of what we're doing. Like we said, we did the IRB-approved study. We're about to complete with the veterans. We are going to publish a case report. We're about to submit it for publication of a gentleman who, I guess I'll say, just underwent a significant psychological trauma, is being closely involved in a mass shooting and whatnot. So we were able to. He sought us out actually, which is pretty amazing. So we were able to give him the ketamine treatment in the very close to the period of time when he had the psychological trauma. And he did quite well, so that is fascinating. So we're publishing that as a case report. We'll be submitting that here in the next couple of weeks and talk about it, because that has some implications as far as, could ketamine be used prophylactically? And, unfortunately, we're seeing obviously a lot more psychological trauma, mass shootings, all those kind of things in the United States. So, perhaps ketamine therapy being included as a part of appropriate counseling and whatnot in the period right after a huge psychological trauma could help prevent PTSD downrange and whatnot. So there's that. We're also looking at potentially doing a study on EMS personnel as well, because PTSD is a huge part of emergency medical services, paramedics, firefighters, police, and whatnot. So yeah, we're trying to do the best we can. We're a small organization. We unfortunately don't have the funding to do huge double-blind placebo-controlled studies. If any of your listeners want to help financially contribute to one of those, we'd be happy to take them up on that and do some bigger studies. But yeah, that's a big part of what we're trying to do. This is the new uncharted territory, and I don't believe in doing back alley medicine. Whatever we do, I want to have scientific basis for it and be able to show people what the evidence is. And if the evidence is not quite as robust as we'd like it to be, then we're going to certainly do what we can to get that studied and published and put that out there. Excellent.
Well, I guess that kind of wraps it up for us, Dr. Bonnett. Thank you for coming on our show, and I'd like to remind everybody that you're listening to Mainstream Mental Health Radio. I'm your host, Dr. John Huber. Remember to follow us at mainstreammentalhealth.org, and that life is what happens while you're making plans, so buckle up.
Thanks for listening to Mainstream Mental Health Radio with your host, Dr. John Huber. Check us out on social media, Google+, Mainstream Mental Health, Instagram @Mainstream Mental Health, Twitter @Mainstream MENTL, and search for Mainstream Mental Health on Facebook. Please tune in every week to Mainstream Mental Health Radio with your host, Dr. John Huber.